There are really limited data about outcomes after aortic valve replacement, or AVR, in patients with really what's called mixed aortic valve disease. And this is the topic of a research letter in the December 13th issue of JACC, specifically looking beyond the ejection fraction. And for this conversation, I am back with Dr. Alexander Egbe, who is an MD and an MPH. Adult Congenital Cardiology is your specialty, and you're at the Mayo Clinic. Let's start with some background. So why did you do this particular paper?
Thank you very much for inviting me for this interview. So, traditionally, aortic valve disease, we've always viewed it as having two dichotomized categories, either stenosis or regurgitation, and we like to think them as being mutually exclusive. But there is it's a spectrum of disease, so there are patients that have both stenosis and regurgitation. So over the years, we've always tried to push them into one of the categories based on the predominant lesion. So mixed aortic valve disease was just a name we coined to describe these patients that have both stenosis and regurgitation combined. And
in some cases, it's congenital heart disease, which is your area of expertise.
Correct.
So this is why you're doing this study.
Yes. So in the patients that we study, those that have bicuspid aortic valve, which is a congenital heart disease, make up close to 1/3 of the cohort. So what we did was that first, to actually study a disease, you need to define it.
Yes.
So we, in our center, we define moderate to severe mixed aortic valve disease as having at least moderate aortic stenosis and at least moderate aortic regurgitation. Oh, okay. So what we now did was so we have a definition, we have a cohort. So in an initial study, we looked at the patients that had only moderate mixed aortic valve disease. So for stenosis, they had only moderate stenosis, velocity of 3.0 to 3.9. So what we found out in that study that was pretty remarkable was that these patients had about the same type of outcome as people with severe aortic stenosis with regards to developing symptoms and requiring aortic valve replacement. So 70% of them had symptoms, required aortic valve replacement, similar to severe aortic stenosis within 5 years.
So it's moderate by name only.
It's moderate by name only, but the outcome is similar to severe aortic stenosis.
So how about the other side, where you looked at the people who had more of a moderate regurgitation?
In that study, we had a couple of control groups. So we're looking at people with moderate mixed aortic valve disease. We compared them to people that had only moderate aortic stenosis, and the outcome was significantly worse in the mixed aortic valve disease, but it was similar to people with severe aortic stenosis. So when we try to look at why this happened, some of them had rapid progression in the severity of valve disease, but a subset of them developed symptoms and required valve replacement even without progression of valve disease. And what we think happened is that a combination of pressure load from stenosis and volume load from regurgitation does something to the left ventricle that make it fall apart and make them become symptomatic.
So they take out a very bad synergy. They do not play well together.
Good. Yeah, that's exactly what happened.
Could maybe the assessment of LV hypertrophy be used as a prognostic tool in determining
yes,
the risk of these patients?
Yeah. So going back to the initial study I talked about, so we found out that the baseline characteristics at the time they present, if you look at how thick the wall is, the concentric hypertrophy as measured by relative wall thickness, that was the strongest predictor of people that will become symptomatic and require aortic valve replacement sooner. So fast forwarding a little bit to the current study that will be coming out in the next issue of JACC. So what we now did was we looked at everyone that has had aortic valve replacement for moderate to severe mixed aortic valve disease. So our objective here now was to see what happens to them after they've had the surgery and recovered and dismissed home. So we looked at a cohort of 283 patients, and they all had aortic valve replacement. A subset had aorta replacement and a coronary artery bypass graft. Perioperative mortality was 2%. So for everyone that was dismissed home, we followed them longitudinally to see how many of them developed adverse events, which we define as having heart failure hospitalization, cardiac death, having severe LV dysfunction, defined as EF less than 35%, or having a stroke. So all these composite adverse events occurred in about 1/4 of the patient. So they've already had successful aortic valve replacement, but 1/4 of them had adverse events. So that begs the question, why?
Right.
So everything about the guidelines for timing of aortic valve replacement, both for stenosis and regurgitation, has the ejection fraction as a pivot as when to intervene.
Correct.
If you intervene when before the onset of reduced ejection fraction, things should be better after aortic valve replacement. If you intervene later on, things will be bad. So that has been the holy grail of timing of aortic valve replacement. These patients that we studied had aortic valve replacement at the time the guidelines stipulated for isolated lesions. More than 80% of them had normal ejection fraction, but they still had these adverse events afterwards. So looking back again at the risk factors, the same thing we found out that if you have thick walls, defined as increased relative wall thickness, those patients tend to be at risk for adverse event even after you've replaced their valves.
So this is in the title, you talk about going beyond the ejection fraction. This is why, because concentric LV hypertrophy is a better predictor of outcome after AVR compared to left ventricular ejection fraction.
In this
and LV
population.
dimensions, and that's in this with mixed aortic valve disease.
Correct.
So what do we do now? I mean, now that we know this, that's really good information. What's the next step?
Looking at it now is that when the one way to think about it is that having combined pressure and volume load for a long time causes the concentric hypertrophy that leads to all these adverse events after aortic valve replacement. A simplistic approach would be to say, let's shorten the duration of at-risk period by performing aortic valve replacement sooner. But this will be oversimplistic because replacing the aortic valve sooner has its own downstream effect because you're dealing now with surgical risk of doing the valve. Correct. You're dealing with prosthetic valve complications, which is structural failure for the bar prosthetic valves and need for anticoagulation for mechanical valves. So this risk has to be balanced out.
But at least we should take away from this that moderate may not be moderate in patients with mixed aortic valve disease.
Correct, correct. So moderate may not be moderate, and think of them as a different disease entity, different from stenosis and different from regurgitation.
And this is the December 13th issue of JACC. The paper is Cardiovascular Adverse Events After Aortic Valve Replacement in Mixed Aortic Valve Disease Beyond the Ejection Fraction. For CardioSource World News and CardioSource World News Interventions, I'm Rick McGuire.